How beta blockers work, a deep dive into one of medicine's most powerful drug classes. Every year, beta blockers save millions of lives, from heart attacks to heart failure, from hypertension to arrhythmias. But how exactly do they work? And why does blocking a receptor in the heart also calm stage fright, treat migraines, and lower eye pressure? Today, we're going deep on beta blockers, the mechanism, the pharmacology, and the clinical pearls that every medical professional needs to know. To understand beta blockers, you first need to understand what they're blocking. The sympathetic nervous system, your fight-or-flight system, releases norepinephrine and epinephrine. These catecholamines bind to adrenergic receptors throughout the body. There are two main families, alpha receptors and beta receptors. Beta-1 receptors live primarily in the heart. When stimulated, they increase heart rate, that's chronotropy, and increase the force of contraction, that's inotropy. They also increase conduction velocity through the AV node, dromotropy. Beta-2 receptors are found in the lungs, blood vessels, uterus, and liver. Stimulation here causes bronchodilation, vasodilation, and glycogenolysis. Beta-3 receptors sit in adipose tissue and the bladder. Beta blockers are competitive antagonists at beta-adrenergic receptors. They bind the receptor but don't activate it. They simply block endogenous catecholamines from doing so. At the cellular level, here's what happens. Normally, norepinephrine binds beta-1, activates a G protein-coupled cascade. GS protein activates adenylyl cyclase, which converts ATP to cyclic AMP. Cyclic AMP activates protein kinase A, which phosphorylates L-type calcium channels, flooding the cell with calcium, driving contraction and increasing heart rate. Beta blockers interrupt this cascade at the receptor level. No receptor activation means no GS signaling, no CAMP rise, no pKa activation, no calcium influx. The result, heart rate drops, contractility falls, and AV conduction slows. Not all beta blockers are equal. Some are cardioselective, meaning they preferentially block beta-1 receptors over beta-2 receptors. Examples include metoprolol, atenolol, bisoprolol, and esmolol. Non-selective beta blockers block both beta-1 and beta-2. Propranolol, carvedilol, libetalol, and nadolol. If you block beta-2 receptors in the lungs, you cause bronchoconstriction, dangerous in asthma or COPD. Cardioselective agents are safer in patients with reactive airway disease.
Beta blockers have an enormous range of clinical indications. In heart failure with reduced ejection fraction, 3 beta blockers have proven mortality benefit: carvedilol, metoprolol succinate, and bisoprolol. They counteract the chronic sympathetic overdrive that remodels and damages the failing heart. In acute MI, early beta blocker use reduces infarct size, prevents arrhythmias, and lowers mortality. In atrial fibrillation, they provide rate control by slowing AV nodal conduction. In hypertension, they reduce cardiac output and reset the baroreceptor reflex. Beyond cardiology, propranolol treats essential tremor, migraine prophylaxis, performance anxiety, thyroid storm, and portal hypertension. Timolol eye drops lower intraocular pressure in glaucoma by reducing aqueous humor production. The side effect profile follows directly from the mechanism: bradycardia and heart block from excessive beta-1 blockade. Avoid in second or third degree AV block without a pacemaker. Bronchospasm from beta-2 blockade. Avoid in asthma. Fatigue and exercise intolerance from reduced cardiac output. Masking hypoglycemia in diabetics. Beta blockers blunt the warning tachycardia, but not diaphoresis. Rebound hypertension on abrupt discontinuation. Always taper. Some beta blockers have special properties. Carvedilol and libetalol also block alpha-1 receptors, adding vasodilation. Esmolol has an ultra-short half-life of about 9 minutes due to hydrolysis by red blood cell esterases, ideal for acute ICU rate control. Sotalol has class 3 antiarrhythmic properties and prolongs the QT interval. used for ventricular arrhythmias but carries risk of torsades de pointes. Beta blockers are one of the most studied, most prescribed, and most impactful drug classes in all of medicine. Understanding their mechanism directly informs how you use them, when you avoid them, and how you counsel your patients. Subscribe to Medical Sciences Unfolded. We go deep on pharmacology, clinical cases, and the science behind medicine every single day.